Okay. So, welcome, dear doctors. On behalf of the directors of Toshbro Medicals, I welcome you and thank you for giving us this opportunity to address you and spending your precious Sunday evening with us. We are grateful for that. Uh, we come today with the subject of dry eye management. Dry eye disease has long been managed with artificial tears and topical drops, but these offer only temporary relief. Today, we introduce iLight, a breakthrough non invasive solution that targets the root causes of dry eye with lasting results and unmatched patient comfort. The program starts with our business development head, Mr. Sanket Patra, giving you a very, very short brief on what this technology is about. After that, we have two very elite speakers, Dr. Anaga Herur and Dr. Rajakumari, addressing you with their own personal experience in managing this disease. Dr. Herur comes with a lot of experience. She has nearly 3 decades in the field of ophthalmology and she has excelled at everything that she has mastered: glaucoma, cataract, LASIK. Dry eye management is her special passion. She's done more than 3,000 patients. She is a well renowned speaker in a lot of very esteemed events like BOA, MOSCON, ESCRS, European Congresses. She's had posters over there. She came to us as a customer, but her dedication, her passion, and her passion to give good service to the people she serves in her area, her geographical area, has endeared her to us, and she stays with us as a friend. Dr. Rajkumari comes from a town called Tenkasi, which is in Tamil Nadu, a very small town. She is very well heeled, young ophthalmologist who has taken up the challenge of doing new things, bringing new technologies into that small area, and she has excelled. So we are going to listen to them and hear and appreciate how they are working, changing paradigms, including new efficacies to the patient's well being, and how they are managing this new dry eye symptoms and disease that has come into our lives because of our work styles. So I hand over to Mr. Sanket Patra, who is going to give you a very small brief about how this technology works. Sanket, over to you.
Thank you, ma'am. I'll first share my screen. Just let me know if you can just see this. Let's see. Is it visible? Perfect. Is it visible? Perfect. So good evening, respected doctors, and thank you, ma'am, for this brief introduction. It's my pleasure today to discuss an incredibly important and often overlooked aspect of your clinical practice, the dry eye disease. My goal is straightforward: to show you how we can effectively treat the cause of dry eye, not just the symptoms, with Expansion's revolutionary dry eye ecosystem. So, the growing epidemic, dry eye disease. Let's start by recognizing the scale of this issue. Globally, if we see, over 750 million people suffer from dry eye disease. Closer home in India, more than 60% of the OPD patients already exhibit signs of ocular surface disease. Crucially, 85% of these cases stem from meibomian gland dysfunction. Sadly, most of these patients remain undiagnosed or inadequately treated. Often, dry eye is recognized only at the advanced stage, significantly limiting treatment conditions. The current management system fails to treat the root cause. So our traditional approaches such as the artificial tears, steroids, warm compressions, gland expressions, and traditional IPL merely manage symptoms. They fail to address the core dysfunction underlying MGD. IPL, whereas alone it targets superficially but neglects the glandular repair. Gland expression, though somewhat it is effective, it is painful, it is temporary, and it is challenging in standardizing it. On the other hand, drops, which we regular prescribe, provide transient relief and not healing. Moreover, many of you may not see the business potential in dry eye treatments due to perceived low patient demand. So what we say is essentially we are treating the smoke and without putting out the fire. Introducing you the Expansion ecosystem. So Expansion is a company from Italy which presents an innovative solution combining precise diagnosis with the comprehensive therapy. The ecosystem integrates MeCheck for quick and accurate diagnosis and iLight, which is a dual modality of treatment which leverages LMLLT, that's light modulation, low-level light therapy, plus the optimized pulse energy IPL for the complete treatment. This unique combination is the only proven system globally that treats all the pathologies related to dry eye, from MGD to Sjogren's syndrome, and even pre and post cataract refractive surgery cares. The game changer, which is the MeCheck. So it's a quick and under 5-minute diagnostic device tool, which offers a painless experience to patients, and it requires no downtime. MeCheck generates instant reports, printed reports, making it an invaluable tool for patient counseling and significantly boosts your treatment conversion rates. MeCheck is certified for optic centers and hospitals. So it doesn't only not only diagnoses, but it also accurately generates revenue. This is a sample report which how the MeCheck produces. We've taken 2 patient reports over here, as we believe that seeing is believing. So patients will now understand their disease once we show them the report printouts to them. And obviously, post this, the acceptance of treatment increases. So there's no more uncertainty or hesitation with patients right now, as clearly it understands, they understand their disease and the importance to take prompt action on the treatment. Now, addressing the investment concerns, we as business owners, we get queries like dry eye is not a priority for patients. The patient flow is very low for dry eye, or it is hard to convince patients to pay for the therapy. So here's the powerful solution to those concerns, which is MeCheck. So if we place a MeCheck in your OPD, we can screen a high volume of patients quickly and efficiently. This device automatically produces clear printed reports that visually explains the patient's ocular surface status, which enables them to easily comprehend the importance of going for the early treatment. So this approach will empower you as a clinician to build a robust, profitable treatment funnel, effortlessly transitioning patients from the initial diagnosis to the active therapy. Now, as I said, the iLight is a dual modality of treatment, which is the LMLLT and the OPE-IPL. We'll first see the first modality of treatment, that is the LMLLT, which is a light modulation, low-level light therapy. This employs photobiomodulation and advanced medical-grade therapy that works at the cellular level and cellular and the mitochondrial level. It stimulates the ATP production by significantly reducing inflammation and promoting cell regeneration, which none of the technologies currently are doing in the market. This was initially developed by NASA for healing wounds in space, as it penetrates deep into the tissues, providing long-lasting relief from conditions like the MGD, Sjogren's syndrome, blepharitis, chalazion, without any discomfort or direct operator's involvement in this. The second modality of treatment, which is the photothermolysis used in the OPE-IPL, unlike the other IPLs. So this precisely targets superficially. This controls heat, liquefies stagnant meibum within the meibobin glands, greatly improving the gland function. Importantly, Espansion's IPL uniquely auto-calibrates to the skin tone. Therefore, there is no requirement of a gel, and it's a gel-free treatment and quick, visible results within just 1 or 2 sessions for conditions like MGD, rosacea, and Demodex blepharitis can be seen with this. Technology that treats the cause, eyelight. So at the heart of the Espansion's ecosystem is the revolutionary eyelight system, again, which combines two patented technologies, the LMLLT and the OPE-IPL. The dual action technology first regenerates glandular cells at the cellular level, though LMLLT promoting sustained tissue healing. Simultaneously, OPE-IPL effectively clears the gland obstruction, immediately restoring glandular function. By addressing both the structural and the functional elements of meibobin gland dysfunction, eyelight provides comprehensive long-term relief, and it's the only complete therapeutic solution available today for all ocular surface disorders. Eyelight also comes with some global clinical proof, as we have currently 5+ papers for chalazion and stye, more than 31+ articles and papers on dry eye disease, more than 3+ papers on blepharitis and Demodex, 2+ on Sjogren's syndrome, 4+ with cataract and refractive surgery, pre and post cataract and refractive surgeries, which Dr. Anaga will again, discuss more in detail in her presentation. So if we can see the outcomes over here in dry eye disease, the chalazion Sjogren's in chalazion and Sjogren's, eyelight has proven superior in resolving persistent chalazia, non-invasively avoiding surgical interventions. In Sjogren's, substantial improvement in tear stability and ocular discomfort in patients who were traditionally unresponsive to standard therapies was seen. In blepharitis and Demodex, significant reduction in inflammation and Demodex populations, improving overall patient comfort. In cataract and refractive surgery, the paper suggests preoperative optimization and postoperative move management greatly enhance the tear film stability, which directly improves the surgical outcomes. This is the eyelight protocol, and we can see over here the combined treatment of IPL and LMLLT is used, or the LMLLT mask alone can treat, the red mask alone can treat a wide number of pathologies of dry eye, starting from MGD till Sjogren's, stye, rosacea, blepharoplasty, chalazion, Demodex, pre and post surgery, all. So this is the treatment recommended protocol which is being suggested. So finally, yes, one ecosystem, multi-pathology and high revenue. So eyelight is not only clinically effective, but also user-friendly, endorsed globally by prominent ophthalmologists. It's a plug-and-play device requiring no special consumables or intensive operator training. Its versatility ensures an exceptionally broad patient base and a strong return on investment by enhancing patient satisfaction with premium ophthalmic practices. Screening, as we mentioned earlier, screening drives volume. Your OPD is already filled with dry eye patients. Many just remain undiagnosed. With MeCheck screening, you immediately identify those patients and even their family members whom you can diagnose. The visible, printable reports will empower patients to make informed decisions, increasing the conversion rates dramatically, almost up to 4-fold. So single platform, full dry eye care. So to summarize, in conclusion, dry eye disease is a hidden epidemic, vastly underdiagnosed and undertreated. Espansion's dry eye ecosystem moves beyond symptomatic relief, offering full spectrum, effective, profitable care. So this is your chance right now to elevate the clinical practice and the patient outcomes. So thank you for your valuable attention. I will now like to shift the podium to Dr. Anaga In the meanwhile, if you have any questions, please write it down or in the chat box or the Q&A session. We'll take the question and answers once doctors finish their presentations in this. Thank you.
It's my pleasure now to welcome Dr. Anaka Hirur. She's going to talk to us about what are the paradigms that she's looking at uh, when she is treating the patients, and what is her experience with the usage of dry eye treatment solution in her practice. So, Dr. Hirur, I hand it over to you.
Yes, ma'am. Can you see the screen? Can you see the screen?
Yes, ma'am.
It says you can launch picture-in-picture mode. Should we say launch?
Launch picture-in-picture mode to watch your meeting.
Yeah.
Launch.
No, just cancel that.
Okay, you can see my screen, right?
Yes,
You
ma'am.
can
You can go to the
see.
presentation.
Yes. Now you can just,
Yes.
and you do the presentation mode. Yeah, okay.
Yeah.
Perfect.
Can you see it? Yeah.
Yes.
Okay. Okay. Thank you.
Perfect.
So very good evening to one and all, and I'd like to thank Shahnaz ma'am and your team for giving me this opportunity. So no financial interest in any one of the products that will be shown here now. So this was the headlines a few years ago. India on the brink of a dry eye disease epidemic. So it said that the prevalence of dry eye disease will be almost about 40% by 2030. And this was a study which was undertaken across 200 locations in various places. Again, this was another study in North India which observed that the prevalence of dry eye disease is almost around 32%, and that too in the age group of 21 to 40 years. So we can imagine that earlier we used to see that the typical patient of dry eye disease was a female around postmenopausal who comes to your OPD treated by multiple other doctors in other OPDs and complaining of irritation, pricking. These patients are easily dismissed. They feel that, the patients feel that that's just a normal part of aging. They are given artificial tears in different places. Brands are changed. But these patients are the ones who need our interest, our validation, and our compassion, because their dry eye is not just a nuisance. It's a real disease requiring real treatments. So if you look at the evaluation of our OPD patients, if you look at our cataract surgery patients, how many times we have had patients who are 6'6", N6 post-op yet unhappy? We know today that more than 75% of these patients had symptoms of dry eye when evaluated, but they were not looked at more in detail. Only 13% of those patients had actually complained about it. If you look at our glaucoma subset of patients, it was found that more than 50% of them actually have dry eye because of so many reasons, especially because of the drops and the preservatives that are continuously being used. Even in children and the teens, it has been shown that almost 40% of them have meibomian gland atrophy, especially because of excessive use of digital devices and contact lenses. In our premium refractive surgery patients, we know today that all these patients may have had dry eye, but if we do not check them in time, then doing a refractive surgery on these patients will not give us the best visual outcomes or happy patients. We today know that our entire dry eye spectrum ranges from aqueous deficiency to evaporative dry eye. There's a big spectrum, and most of them have a combination also of the two. So what we need to do in our OPD practice is to identify these patients Look at what are the predisposing factors. Today, age is no bar, as we saw, especially menopause because of decreased androgens. Look at what are their lifestyle choices, what are the environment where they are working, whether they have undergone any surgery, what are the medications that they are using, how much is the time that they are spending on digital devices. They say more than 2 hours of digital device exposure, you are at risk of computer vision syndrome or digital eye strain, which includes dry eye disease. These are a list of medications that can trigger or increase or exacerbate dry eye disease. How many times we have gone back and asked patients what tablets they are on, whether it's topical or systemic medications. So basically, these cause irritation, inflammation, tear deficiency, and this becomes a vicious circle. So these are the signs and symptoms which we need to pick up. Now, when we look at meibomian gland disease, which is basically causing evaporative dry eye, we know today that hyperkeratinization of the meibomian ductal system, increased viscosity of the meibum, both cause obstruction of the meibomian glands. And this can be best picked up by doing a simple meibography. So we have to grade our patients, whether it is 0 to 25%, grade 1, with 26 to 50%, grade 2, 50 to 75%, grade 3, more than 75%. So this is a very simple test which you can actually show. So all my patients, I actually have this slide in front of me and show them how these gray areas actually mean that their glands are shortened, there is a loss of glands, and if left alone, if not treated in time, they can increase to a greater significant gland loss. Yes, you need to be clinically very alert and look for various other signs of meibomian gland dysfunction also, so that you actually come to a diagnosis. But friends, remember that there is a very poor correlation between signs and symptoms. Now, these studies have shown that asymptomatic MGD is twice as common as symptomatic MGD. So a patient may not come to you complaining of pricking, irritation, burning, whatever. So you need to pick them up from their signs as well as the tests that you're going to perform. So what do I do in my practice? So the optometrist level and the ophthalmological level, both are very important. So when the optometrist is taking history, you ask for history of any symptoms of dryness, but more importantly, also ask for history of predisposing factors, systemic history, medications, and then the ophthalmologist evaluates whether the patient has any signs of MGD, whether the patient is due for refractive surgery, cataract surgery, especially premium IOLs, because you don't want them to be unhappy after surgery. Glaucoma patients, if they are contact lens users, if they are using PCs or smartphones, tablets for an extensive time. So all these patients are your potential dry eye patients. So we do a basic workup. We do OSDI scoring, corneal staining, TBAT, Schirmer's, and meibography. So all these tests for all these patients. And me check definitely helps to immediately, very quickly give them an idea as to what's happening. Now, when you go on to treat these patients, we know that medical management today, you can put them on lubricant eye drops, gels, but these are all symptomatic relief. We tell the patients that the drops that they're going to be put are basically tear substitutes, and they're the time that is going to take or the relief will be only temporary, so if for a few hours. But what happens beyond that? Because we are not treating the cause when you're giving just tear substitutes. Even if you add on anti-inflammatory, you basically need to treat the cause. So treat the lid margin disease. So today we have the greater, higher technology in our armamentarium for dry eye management in the form of these therapies. So you need to be updated with these latest treatments, explore these avenues, and make those treatments accessible to our patients, keeping the costs factor also in mind. So I've been using this eyelight technology for the last almost 6 years, and with very, very good results. So I will not go into details of how these work because Mr. Sanket has already explained to us. So it's basically the direct treatment, which has the photobiomodulation, and the indirect treatment with the intense pulse light therapy, which helps to buy both together. It's the dual treatment. So I use both these modalities for all my patients. And they are extremely happy because it's non-invasive, no anesthesia required, very quickly performed. And as we know that it works at the directly at the cell level, it's not just superficial. So many patients ask me, so what if I just give warm compresses at home? Will that work? Will that help to replace these technologies? So the answer is no, because we are not just treating at the skin level. It is directly, it's a deep thermal treatment, and this helps to improve the glandular function. It improves the tear film stability, and the best part is the paramedical staff can do it. It can be sent from center to center. Today I'm operating at 5 centers, and these patients can be treated very well. So it has a lot of advantages. I usually follow the 0-15-30 rule, that is 3 sittings at an interval of 15 to 30 days. And many of our patients find relief even after the first treatment. Yes, there could be patients where maintenance treatment is done, especially if they have other predisposing factors. Side effects are very minimal, mainly just barely some redness or tenderness, especially if the skin pigmentation is more. It's extremely cost effective, especially compared to the other options that we have today, which are very, very highly expensive. These are a few contraindications where we need to be very careful and avoid doing these treatments. So a lot of literature now today, especially those before surgery. Now, for example, if you have a cataract surgery, we, especially for multifocal IOLs, we do dry workup for them. And in these patients, at least one treatment before cataract, even for the refractive surgery, and then continue with medical treatment. And post surgery, we give the other 2 sittings of the IPL treatment. So the LLT also is working very well. For all our MGD, again, we give 3 treatments. So these are some literature. So this was a article where the outcomes have been shown to be extremely good. And today we have the OSDI scores coming down, the symptom reducing, plus you have the T-BUT also showing changes. So this was another multi-center study of the IPL treatment with refractory meibomian gland dysfunction. This was in very surprisingly, even in Sjogren syndrome, which is an aqueous deficiency. Here, many of these patients may have a evaporative dry eye component also. So eyelight seems to work well in these cases. This was another multi-center comparative trial where it shows superior long-term OSDI changes. And even in pediatric young patients where contact lenses are being used, there is improved lens tolerance, decreased dry eye symptoms. Like I said earlier, so combination therapy of IPL along with the LLLT gives much better results, almost 70% even after one treatment. So you have other future applications also, and other in other fields too. So you have these, what research shows in cataract, in chalazion, in demodex, in contact lens related patients, in Sjogren's, and definitely in meibomian gland dysfunction with all these cases. So basically, in my own experience, so this was what we found in the first 500 eyes. We have gone now much beyond that. So even after the first sitting, we call the patient back after a week to look for any subjective improvement, and almost 80% showed improvement, and 54% showed more than 50% improvement. After 1 month, when we evaluated them again, 71% showed improvement and 68% showed more than 40% improvement. And these are just a few patients. So this was a 37-year-old male who was constantly on the PC, and he showed 50% improvement in symptoms. And post IPL 3 months, you can see the T-BUT improved from 2 to 8 seconds, and in the left eye 3 to 8 seconds. In this 69-year-old female who was also a diabetic, 60% improvement in symptoms. You can see that one eye there was a T-BUT improvement, in the other eye, even though the T-BUT did not show so much of improvement, the symptomatically she was very, very comfortable. This was another patient, 60-year-old male who was on antihypertensives, 30% improvement, and the T-BUT was almost the same. So this was another 67-year-old patient. However, on mybography, when you see, there are very subtle changes. Sometimes there could be edema, and that reduces, and that can also show up in the changes in the myopography. Many of these patients have given us excellent Google reviews. So, for example, this patient showed that he mentioned that even after the first sitting, the IPL treatment, the pricking and itching totally vanished. This patient, he mentioned how 80% positive result he got within just 1 month. Overall experience good. This was another patient, 60% improvement within a week itself. And this another patient who showed 50% improvement after starting the treatment. So this was one patient who gave her testimonial. I know this is in Marathi, many may not be able to comprehend, but she was having severe irritation, pricking, and she was not even able to watch television properly. So she went through this treatment and she was really comfortable. This was another patient who was having severe problems, 6 months, 1 year. She went from place to place. She was not able to, comprehend what was wrong with the eyes. Then when we started her on IPL treatment, then her improvement was very, very significant compared to just the medical treatment. So if you look at morphologically evolution of the meibomian gland, so what exactly happens and what exactly changes after this treatment? So they say that according to this study, so there are stem cells that are found in the ductal epithelium of the glandular acini. And once the IPL treatment occurs, so these are the opening improves. So, and that is why these stem cells can actually penetrate and then regeneration occurs. So probably that is how these meibomian glands actually can start reworking. So these, we need to explore the reversibility of meibomian gland atrophy in all these patients. So when you look at factors that are considered for the selection of any kind of treatment modality, we look at efficacy, we look at results, we look at the modalities, the technology, the safety, the ease of treatment, and the patient comfort. And I'm really happy to say that iLight has been, on all these counts, really very, very good. And today, with good efficacy and results, good modality, technology, and safety, and ease of treatment, patient comfort, as well as, it's light on the pockets of the patient. Today, I feel newer technologies is putting meibomian gland dysfunction management on the fast track. I have been using also the surgical technologies in the form of the earthly machine, and I'm being very happy with all this. So thank you so much for this opportunity. Thank you so much.
Thank you so much for the enlightening talk that you gave us, Doctor. I was very surprised when you said that more than 50% of glaucoma patients are dry eye patients. That's a huge, huge number. And a lot of people are suffering without really diagnosing what is wrong with that. So you've really thrown good light on what we don't know as laymen, I guess. So thank you very much. I want to say something about Dr. Anaga, that apart from being such a brilliant surgeon, she is also a multicultural person. In my opinion, I know her now for so many years. She is what we call in our Sanskriti, what we call a Sarvagun Sampanna person. She is a dancios, classical dancing. She is amazing in that. She is a poetess. She writes beautifully, besides being a very compassionate human being. So thank you, Dr. Anga, so much. It is really nice and a privilege to know you and have you as a customer. Thank you.
Thank you so much, ma'am. Thank you.
I now invite Dr. Rajakumari. Dr. Rajakumari is from Tenkasi. Dr. Rajkumari, thank you for being here and thank you for being a customer and thank you for being one of the bold people coming from a small town, practicing in a small town, but having a very big vision of bringing really high tech into that area. So we would like to hear about your experience of doing this in your region. So over to you, Doctor. Thank you.
You're not audible, ma'am. Dr. Rajakumar, you're not audible.
Thank you for this opportunity. I would like to start with this. How can we do dry eye diagnosis and management in a small town? So you heard from an expert from a metro city, and now it's from a tier 3 town. And one might wonder what a retina person is going to talk about dry eye. Dry eye is everywhere. Dry eye patients are everywhere. So it's our duty to actually screen everyone who comes into our office for any problem. So how do we actually start with this? So first, let me tell you, Tamil Nadu is located down south, and Tenkasi is a very small town in Tamil Nadu, and this is my roadmap for doing a good dry eye practice. So it all starts with how we screen the patient. Um, Essentially, the dry eye patient doesn't come and tell us that they have a dry eye. They may come with various problems. Sometimes they may be mute, they may not tell anything, but looking at the eye, we may find out that they have a dry eye. But developing a proper screening protocol is very essential. So, every pre-cataract worker patient needs to have a dry eye checkup, and anybody for whom we might suggest a lubricating drop should ideally go for a knee check for a proper a full dry eye evaluation if time permits, or at least mammography. A knee check is a very valuable tool to do that, and screening often helps us understand what's going on, whether there is a meibomian gland dysfunction or is an aqueous deficiency, and it also helps the patient understand. So, patient education is very, very important in making them understand that this is the reason for all the other symptoms that they have come to the clinic with, and it helps us also to give them a better treatment. So, screening the patient is very vital in developing a good clinical practice. And once we have screened, we have to give them the options. Not every patient is happy with drop. There is always a subset of patients who are unhappy with drops, and identifying them is the key in having a successful clinical dry eye practice. And there is also a subset of patients who don't want any other treatment, who want to try drops first. So we have to respect the patient's choice. So we can explain to them, some patients may not be able to afford the full treatment. So we can give them a trial of drops for a month, but always explain that there is a better targeted root cause resolution, and this may not help for a long term. And so identifying the patient and giving a proper counseling is very important to make them understand, and the importance of IPL and the long term benefits of having an IPL therapy. So we don't hard sell, we just have a honest communication, because most patient wants to have the explanation and then decide about the management. So spending some time talking to them, actually, there are patients who come with practical difficulties, like I'm alone, I cannot put drop on my eyes myself. I don't have anyone to put drops. So there are a lot of difficulties a patient have. So it's always good to give them a better solution, and spending that extra 2 minutes, extra 3 minutes will always help them understand the actual benefits of IPL, and they will automatically choose a better treatment protocol. And since we have highlight retreats, as it's been discussed elaborately by both the speakers, so I think I'm not going to talk in detail about what are the benefits of getting this eyelid treatment, what are the various diseases for which it's helpful. So it's not just about the eligibility, it's about tailoring the treatment correctly to the patient, and making a happy patient. So one size actually doesn't fit all. We have to find out the patient's timing. Sometimes we get patients who come from abroad for just a week's vacation or 2 weeks vacation, so they may not be able to complete the full treatment. So we tell them about the treatment, we give them 1 or 2 sessions and then ask them to plan their next vacation properly. And I have had patients who have come back to me keeping this in mind, so that next time when they come back to India, they plan it accordingly and they come day one after reaching India to get this treatment done, and they finish all the 3 or 4 sessions, whichever is needed for them. And this really helps the patient in a long term. And I have to tell this, I started my eyelid treatment for my patients. Um, this is my third year, for 3 years in a row, and none of the patients for whom I had treated the first year came back with the same problem. They're actually happy. They come back to me for their refraction or for their cataract, but not for the dry eye disease. Most of them are happy. Sometimes they may need just maintenance with the mask, or 1 session of IPL and the mask in maybe after a year or so, but they're really happy with the treatment. And on a long term basis, this is really good. And we can actually identify the pre-op patients and give 1 or 2 sessions before cataract, and then 1 or 2 post cataract. And this really helps with all the patients who are having this some watering sensation, some seeing through the water feel after cataract surgery. All these vanishes when they get a post cataract treatment with eyelight. And this actually adds values to premium cataract patients. And I don't do refractive packages, but it should be helpful to those patients as well. And this overall improves the patient satisfaction and the visual comfort. Dependence on long-term drops is reduced. And these dry eye patients somehow have a very good word of mouth referrals, and I get patients who have done IPL with me and then sending more patients for IPL. And it's really good to improve our practice as well. And so starting lean and growing purposefully actually helps. So we have to begin with a good OPD screening, and I keep my screening charges low. That's one key. I keep it very low so that the charges for screening is never a hindrance for them to get it done. And I also keep my treatment charges low because I'm in a tier 3 town, and I want to keep all charges low so that it benefits my patients. So keeping the screening charges low actually makes more people afford, more people get the screening done, and that in turn increases the revenue as well. And also more people getting IPL also increases, and I keep my IPL charges also low. And this is the roadmap which I have been following, and it has given me a sustainable growth. Thank you.
Thank you, Dr. Rajkumari. That was very insightful. In fact, you have given us a nice slogan: start lean and grow purposefully. That applies to all fields of life. And thank you for a very good lecture on how you have attained growth in your region.
I never knew that I had dry eye until I had my IPL done.
Okay.
So some patients don't have this. They don't come to us with dry eye problems. But what I noticed is post IPL, it's the absence of a display, unpleasant sensation. That's the result. We are so used to that unpleasant sensation that once the IPL is done, there is that absence of unpleasant sensation, and that's the difference we experience. So I never knew that I had dry eye till then.
Okay.
I've not even taken a teardrop before.
Okay. Thank you. Thank you so much. So I think there aren't any questions. Are there any? Sanket? Are there any questions for the doctors? I don't believe there are. So
No.
we can end over here. Thank you very much, everybody, for being with us.
That is okay.
Thank you, speakers. Thank you, doctors, for spending your evening with us today. And I'm really grateful to the brilliant speakers who gave us so many insights. So we can end the day today over here. Good evening and thank you again.
Thank you. Thank you, ma'am.
Thank you.
There are some questions coming up now. I'm sorry. I think we can answer most of these things. Somebody is asking whether they can treat VKC and post-LASIK patients with eyelight, LLLT or IPL. Can doctors answer? Dr. Anaga, Dr. Rajkumari, can you answer that?
It's LLLT.
Yeah. They are asking what the treatment of VKC.
VKC and post-LASIK patients with eyelight. Should they do it with LLLT or IPL or both? That's the question.
No, basically you need to evaluate these patients from NGD perspective. If they are having meibomian gland dropout, treat them like a proper dry eye patient. Always do a T-bar-T or meibography, and then look for gland dropouts, and then you can treat them accordingly. So it's a post-LASIK patient. It's not necessarily only because of post-LASIK. There may be a part of NGD also, or evaporative dry eye component, which definitely, and whenever I treat with both LLLT as well as IPL. But VKC is more in children. The pathology is different. So you need to treat the VKC in a different way. So I don't think that can be treated by LLT.
Okay. Dr. Helen is asking how much the system costs and all that we can answer independently. I don't think there are any application or medical questions for the doctors. So we can close the evening today.
But there are a couple of more questions actually.
They're coming in? Okay.
Yeah.
Would you like to answer? Somebody?
Yes.
Is eyelight therapy enough or IPL also necessary? That is the question Dr. Ajit has been asking.
But for what?
So I usually combine. So if you are talking about meibomian gland dysfunction, then I usually combine both the mask as well as the IPL, LLLT plus. That gives best results. Madam, if you want to say, Rajkumari.
Dr. Rajkumari, you have anything to add?
No, that's the same. I do.
Any other questions?
Kuntal, any other questions that you can see?
No, I cannot. That was the last question.
That was the last question. Okay.
Thank you so much.
Okay. Thank you. Bye-bye. Thank you.
And
See you soon. Yeah. Bye.